My name is Professor Ezechi. I'm primarily a gynecologist and a director of research in the clinical sciences departments. I'm a fellow of both the National College and West African Postgraduate Medical College. I also have a PhD in public health and also a fellow of Nigerian Academy of Medicine and a fellow of Nigerian Academy of Medical Specialties. I'm also a member of Lagos State Health Research Ethics Committee and the National Health Research Ethics Committee, and a member of National Task Team on HIV treatment. I'm also a member of the Scientific Committee of Nigerian Committee on Cervical Cancer Elimination. Because of this chart, we were supposed to be, that cervical cancer elimination in Nigeria is being launched in the Asobila today. But because of the importance, the Institute attached to this video chart, I'm here, I'm not there. By my side is Dr. Abidin, consultant pediatrician. Please introduce yourself.
Good morning, everyone. I'm Abidin Salako. I'm consultant pediatrician and a research fellow here at the Nigerian Center of Research. As my designation implies, I'm a pediatrician. My interest is more of child health. It cuts across from birth up to 18 years when you no longer want to become a child and you want to be seen as an adult. But I know these days we all want to be children because we remain children for the rest of our lives because once we are parents and we are children. Again, my area of interest means child health, adolescent health. Sickle cell also is a bit central in what I do, in addition to all other child-related and public health-related research that is aimed at promoting health and changing the abysmal narrative of the Nigerian population. Thank you.
Yeah.
All right, thank you very much. Good morning, everyone. My name is Dr. Falaumi Akishulu. I'm a research fellow at the department, at the Clinical Science Department at NIMR. I hold a PhD in public health from the University of Debrecen in Hungary. What I do basically, I'm also a member of the scientific committee at the Department of Clinical Science as well too. I'm also a member of the IRB, that's the Institutional Review Board for the Nigerian Institute of Medical Research. I also majorly my area of expertise basically is in cervical cancer, HPV, and also neglected tropical disease. So I do quite a number of things on neglected tropical disease. I conduct systematic review, and I would say that majorly all I try to do is doing more of things in the implementation science that has to do with public health importance. Thank you.
So you could see that between three of us, that my area of focus is maternal, child, adolescent health, infectious diseases, sickle cell diseases, all bordering about maternal, reproductive, and child health. And you also notice that, like Didi talked about clinical research, there's an element of, when you're doing clinical research, there's an element of public health there, the element of, he didn't talk about the ethics, the member of NIMR ethics committee there, because people are dealing with a vulnerable group, mother and child and adolescents. If you also know, to be in a clinical department or a team, we have three main trusts in what we do. First is health service to support research. Because when you are doing clinical research, you need to also to have a clinical services provided for you to be able to next your research in that. And this area will provide care to people living with HIV/AIDS. We also provide prevention of mother-to-child transmission, and which will tell you in the institute, we started in 2004 when we started prevention of mother-to-child transmission. And in the last 4 years, no single mother who passed through the clinic have had a baby that HIV positive. So in this institute, we've shown that it's possible to achieve zero to mother transmission facility, showing that the most important is the drug, ensuring that every HIV positive mother swallows that drug. We also provide cumulatively provide HIV care to over 25,000 patients since we started in 2004, and we'll continue to do that. We also provide some cervical cancer screening services at the clinic there, which also supports our research in the area of cervical cancer, and we also impact on HPV vaccination. Because of the hesitancy we had during Nigerian rollouts, we also have research, what we call mother-daughter dyad. The essence is that to promote cervical cancer screening by offering the mother cervical cancer screening and offering, if they have a child that between 9 to 13 years of age, to also try to educate them on the importance of vaccinating their daughter. We also have a capacity building effort for research, because as we are getting old, we will soon retire. We also need to bring up new, younger people to embrace research. We have 2 programs to enhance research capacity of younger person. The one is what we call NIMR Nigerian Research Training Program, where we train young faculties and young researchers to learn how the rudiments of responsible conduct of research, how to write grants writing, because you need funds to do your research work, and also how to do ethical research. That we are doing in collaboration with Emory University in the United States, University of Lagos, and EPIN Public Health Initiative. We also have another one we call the Cancer Control Center for Research on Implementation Science. Like the DG said, when you are talking about clinical sciences, as you are doing your research, you're also providing services. So we are teaching young faculties on how to do that simultaneously. As you are providing services, you're also conducting research. The SARMAAN project, we are going to talk in detail later, embodies that. We are providing service to children, we are at the same time conducting research. And finally, the third aspect of what we do is research for national health. And we have a number of projects, research projects that borders on cervical cancer, borders on hepatitis, borders on non-communicable diseases among HIV positive. We all know that before now, what kills HIV positive patients is tuberculosis, infectious diseases. But now we've controlled those infectious disease processes. A lot of them are now dying from non-communicable disease of hypertension, diabetes, and we now have a research project that's trying to evaluate integrating hypertension care within the HIV positive population using what we call tax shifting strategy. The doctors are very busy providing HIV care, and most times providing care for non-communicable disease like hypertension is lost. We are now saying, doctors, you are very busy. Can the nurses and other people provide that hypertension care? And what do? We selected 30 PACs in Lagos State and randomized them into 2 groups. One group will do the standard thing we do. One group where we'll tax shift and nurses start ensuring that at every visit they educate them about hypertension. And we are beginning to see that in that group that we tax shift, that the nurses are beginning to do some of that things, while doctors are concentrating on seeing the patient, that the outcome is better. We are hoping that when we conclude that study later in August, that we will write a policy statement for the government to adopt that tax shifting within HIV care. Now moving to the project, because of the number of projects we have, almost up to 10 research projects. We cannot discuss that in one session like this. Some of our other team members from time to time will also discuss that, but we are focusing on SARMAAN projects. SARMAAN project is called the Safety and Antimicrobial Resistance of Mass Administration of Azithromycin in children. In 2022, WHO came up with a guideline which says that in countries with infant mortality of 60 per 1,000 live births and under 5 mortality of 80 per 1,000 live births, that they should introduce mass admission as additional child survival strategy in order to reduce the high infant mortality. And we know when you talk about maternal mortality and infant mortality, Nigeria top on the list. And the then Minister of Health, Dr. Ezechi, consulted a number of other MDAs, agencies, to try and do that work, to evaluate it. But after 1 year of failure of some of those other agencies, they called NIMR to say, we don't want to implement WHO recommendation wholesale. We want to implement it limited to see whether one is safe, whether it's effective, and also whether it's cost effective. And they called on NIMR, and I was called to lead the team, and we came up with the proposal to do that. And we are lucky, Gates Foundation said they're going to fund it. And our objective was to, one, evaluate, is this drug safe? You know, when you introduce antibiotics, the antimicrobial resistance may develop. So we wanted to make sure that you are not trying to solve one problem while you are now creating another problem. So, safety, is this drug safe in children? Is the antimicrobial resistance increasing? And yes, we want to do this. Is it actually cost effective? Because you want to ride a Cadillac, but if you don't have money to buy a Cadillac, you settle for a Volkswagen. So that's one of the things. And then the country didn't want to run another parallel program. You know what normally happens in Nigeria is that you bring a new program, it's running parallel. Once the funding finishes, what happens? That program dies. The minister then said, no, I don't want to. So we should also evaluate different platforms in the country, be it National Immunization Program, be it seasonal malaria prophylaxis, be NTD, to evaluate which one of them will be cost effective in terms of integrating this SARMAAN project into that. And that's what we did in the last 2 years. And that's what we called SARMAAN 1. We selectively selected because in the country, if you do a research project and it's only in one part of the country, people will say, there will be issues. So you have to put political consideration, political and cultural consideration. So we selected 6 states in the country, 3 in the high infant mortality endemic states in the north, and 3 wanted to select 3, but one of the states, which I won't mention here, vehemently refused that we should not implement, despite these 2 repeatedly writing to them, they don't want to participate. So the state that was selected is Akwa Ibom, Ikono local government in Akwa Ibom, in Abia State, Umunochi local government, in Kebbi State, Kano State, that's Wamako, and then in Sokoto, Wamako. Wamako is
Sokoto,
Kura local government. So these are, we implemented fully in Kano and Jigawa, the entire state. But in Kano was a Kura and Sokoto was Wamako local government. While in Abia State, we implemented in Umunochi local government and in Akwa Ibom, in Ikono local government. With other partners, this is a partner ensuring that every key player in Nigerian health system space is involved. NAFDAC was involved, National Primary Care was involved, other development partners and site savers were also involved, and then all the states where we are. But NIMR was leading the research components. We implemented that for 2 years. every 6 months, first of all, we conducted a baseline studies to collect the data, the baseline infant mortality in those places. And then every 6 months, we dose these children with mass azithromycin. After that 2 years, our results were positive. We proved some things which Dr. Abidin will talk about achievements. And based on that and some of the other results emerging from Niger, Mali, they have a study where similar studies also being done. Instead of restricting the drug to 1 month to 11 months, we decided to expand the drug dosing to 1 to 59 months of age. And that's how we started on SARMAAN 2. One of the things that our research was not powered to do in SARMAAN 1 is actually to measure morbidity and mortality. Because when we started presenting our findings at national stakeholders meeting, the question everybody keep asking is that, yes, you said the drug profile is safe. You said, yes, antimicrobial resistance is not increasing. You said, yes, it's cost effective. But how many lives we are saved by? So in the SARMAAN 2, we calculated our study sample size to empower us to make a statement about maternal mortality. So in this, we also realized that this intervention is more effective in states or areas where the infant mortality and morbidity is high. So what it means that it's more cost effective to go to where the deaths are high. And that's why we decided in SARMAAN 2 to focus on 11 high infant mortality endemic states in the north. And these states are same Kano, Kaduna, Katsina, Sokoto, Kebbi, Jigawa, Borno, Bauchi, Zamfara. So these are the 11 high endemic infant mortality states that will be focusing on there. The essence is that while we are doing research, we're ensuring that any eligible child in that environment swallows the drug. And exactly the same thing we did in SARMAAN 1. That's where the clinical research is completely different from other research. It's an unethical. WHO have come up with a guideline saying this drug is useful. It would be unethical not to give a child that drug. In Niger, what they are doing, they randomize it and say they will give one set of children, they will not give one set of children to see. But in Nigeria, the ethics committee, I'm an ethicist, and the number of people, we said no. The WHO have come out with a guideline. It's unethical not to give some children. And so what we are going to do, in Kano, we are going to conduct a study using a method called step weight, in which every child will get the drug. But we introduce local government by, one after the other, one after the other. While you are starting with some local government, the other ones acting as control. But in 3 months' time, every child keep getting that. That's what we are adopted in this. We are ongoing now in Kano, Kaduna, Bauchi, and Katsina. We've conducted a baseline assessment and also collecting data for AMR in these 4 states. We are going to move to the other states. I'm happy to mention here that the 4 journalists were with us in Kano to observe what we are doing. I'm sure they saw the massive number of persons we are training, because data collectors, these are community-based people who are not doing research before, but we have to train them to be able to collect because of the enormous number of persons. The other journalists will also have opportunity to go to other states to also witness first-hand information of what we are doing in the field. I think I need to pause here and to allow my colleague Abidin to talk about what we achieved so far before I pass that to Dr. Fola to talk about, the way I presented it look rosy, but also present some of the challenges we're encountering as you do, when you do a community-based study, or do population-based study, you have a lot of challenges you encounter, which is quite different from staying in NIMR here and doing research. But when you are now in the field conducting a clinical research, it comes with a lot of challenges. Dr. Abidin, let me hand over to you.
Thank you very much for the groundwork. It's almost saying, but most importantly, I think the first thing is you say that the project gives NIMR the opportunity to his vision, because again, you go by the vision of NIMR, which is excellence in basic, applied, and operational research of promoting national health. That national health at this point is child health. If we could check narratives of our children surviving, then the future is a lot brighter for us. I think that's one thing the project is doing, and I think it's doing well. Ability to promote that our vision, and also the mission of the institute. But most importantly, it gives us, again, it's giving us that opportunity to collaborate. Again, this is one project that has brought who is who in child health onto the table. NAFDAC, National Malaria Elimination Program, Neglected Tropical Disease Program. The Federal Ministry of Health itself, Department of Family Health and Child Health, are on this also with us. Again, it's helping not just to take NIMR out, but again, bridge that collaboration between NIMR and the sister institution. And again, as much as possible, we have the Federal Ministry of Health being anchored there. That is the umbrella which we all sit under. The other big thing is opening up the relationship between NIMR and private institutions. Again, this is one good thing which again latches on our mission as an institution. Site-savers, Solina, Mitosat, Affinet, they are all on board with us. But it's not limiting us to local collaboration. Again, it's opening the windows to international collaborations. You have University of Washington also on board with us. The Masters of Implementation Science, we're able to relate with them. University of Duke, which again is forefront in step work design that we're adopting. And they are saying even this is almost the first time it's going to be adopted in our own environment compared to the other environment where sites are better delineated. That's one thing. Achieving our mandate, improving collaboration, but most importantly, we're also able to establish that the drug is safe in SARMAAN 1. And that has opened up opportunity for SARMAAN 2, and which we are pushing up beyond 1 to 11 months to 1 to 59 months. Antimicrobial resistance, it's a canker worm everybody wants to curtail. This gives NIMR the position, not just as a research institute to speak, but again to contribute to science beyond the Nigerian space, but in the global space. We can boldly say that we've been able to distribute 1.8 million doses in SARMAAN 1. In those 6 states we are in, across 52 local governments, and a total of, and then we are expanding. Kaduna, as we are speaking now, Kaduna and Kebbi, they are rolling out 100% to every local government, every child 1 to 59 months, except if the child doesn't meet the criteria. Employment opportunities, the economy hasn't been good, but again, you are not just building capacity, you are helping people to provide daily meals, because if you are able to employ people to be part of your research team, directly or indirectly, again, you empower them economically, because again, they get paid a stipend for that. So employment opportunity, state ownership. We're not just doing it and say we are coming in and say, oh, we are NIMR, we want to do it. No, the state is with us. They are our voice. They are leading us. So again, they are helping to guide how we work and how we relate in those states. So bigger collaboration beyond NIMR, being in Lagos and in Abuja and in our satellite institutions. We are now spreading our tentacles to states where NIMR doesn't have an office. So they're opening up the states. But most importantly, I think, is on the side of the children and the parents. As you go from community to community, and as you hear the narratives of mothers, and they tell you, oh, we're happy, our children are no longer having respiratory tract infection. The diarrhea burden is coming down. The rashes we see often with azithromycin, you've been giving us once every 6 months, is on the down. And then so there is caregiver acceptance. And we are not just giving it and forcing it down their throat. They are now becoming the advocate of improve health, this is how you want us to do it, this is how we should do it. And I think these are successful stories that If we build on and if we large on, then NIMR really can continue to hold the space as the Nigerian Institute of Medical Research and the foremost institute in research conduct in the country. Thank you, sir.
Yeah, thank you. Just like I begin, I've just mentioned, to tell you how acceptable mass additional expenses things happen. A parent called me from Sokoto and said, why is my child not being given the drug? Because in our consent form there, my name and contact is there. And the parent called. They gave me last cycle. Why are you? Because the child have outgrown, children keep growing. The child have outgrown, and I have to explain to you. Even some other parents even mentioned that, that they are ready, because we are talking of sustainability, and we are asking something. They said they are even ready to contribute to ensuring that this program is sustained. It's not rosy, it's not so easy, it's not, you could see everything is completely drained from the field, and some of you who have been in the northern part of the country see temperatures so high, 40 something, and you get a cold water, and by the time 2, 3, 4 minutes it becomes hot water. So Dr. Akisoni will share with us some of the challenges we've encountered and will continue to encounter in the
all right, thank you so much, Professor Ezechi and Dr. Abidin.
go ahead.
All right, I would say that the situation is the good, the bad, and the ugly one, whereby Prof has given you an overview, and Dr. Abidin has also talked about the achievement, but I would say that all these are their own challenges in place. And I would say that one of the major ones that we encountered was that most policymakers and stakeholders, they don't understand the critical role research actually plays in driving sustainable development. And if you listen carefully, in SARMAAN, there were some states that were supposed to go, but they refused. So you can imagine we've been able to identify that there's a high prevalence of this particular situation in your state, and we would like to come and implement, and you say no. So that's one thing that we've been seeing. And it's not only in that state, even though that state's rejected outrightly, there's some states that before we can even start implementation, it's a big challenge. We have to face a lot of rigor. In SARMAAN, we had to go and do re-advocacy like 6 times. So like you're going back to the same group of people 6 times to tell them that this is what we want to do and this is why it is important for us to work around it. Then another challenge that we have is the inadequate laboratory structure. So you can imagine we're trying to bring all samples from the northern parts of Nigeria down to Lagos to analyze in NIMR. Do you know what that is? It's a lot of money. But if we have those laboratories over there functional, working properly, there's no need for us to transport those samples all the way from the northern parts down to Lagos to analyze and then tell them that this is the result we have. So I think most of those labs are not well equipped, and I think it's a major challenge that is also constraining and affecting our logistics here in the implementation of the SARMAAN project. Then the northern part, I'm quite sure some of us know how it looks like. The terrain, there's some areas they will tell you not to go. There's some local governments you want to implement in all local governments, and they'll tell this particular local government, this particular one, it's no-go area. Last year, some of the research assistants were attacked in some local governments, and these were some of the things that we face. So sometimes when we say that, oh, it's a good thing, there is this part of it that is bad, and there is this part of it that is actually very ugly. Then another thing else I think we should also look into is the shortage of skilled human resources, and that's why we have to do training. Sometimes we have to do retraining. Even while they're on the field, we have to follow up with the research assistant to ensure that they're doing the right thing. So we don't really have more skilled people, and that's why sometimes we have to bring people from NIMR to go over to those states to actually see what is going on, because if we are not there, whatever they will send to us is whatever we're going to receive, and at that point all our resources at that point are wasted. So that's the reason why sometimes we have to be there to see what they are doing day by day, to monitor at the back end that the data are coming in, they're collecting the samples the way they're supposed to collect them. Because if we don't monitor them, we just find out that whatever they're collecting is what we're just going to work with, and that will not give us what we hope to get at the end of the day. Then I would say that logistics culture and sustainability constraints is also one major thing. So the logistics of travels, we've moved in a particular place in Kano for 2 hours and we couldn't see anybody. We're in the Marua, but we needed to go to that particular place, had to reach area. So these are some of the things that we face on the field, and these are some of the challenges that we're looking into in such a way that reaching this underserved population is actually a big thing. But the question is, do we have to? Yes, we have to, because that is the main aim of the project. Thank you, sir.
Yeah, thank you so much. So listening to some of the things you've said, we've, in some of the, like you said, we are still get a lot of Nigerians who think research is bring money, let's share. And you are trying to tell them that this is to make sure that our children stop dying. And they are telling you, we are not interested. What we get is that is still, and generally, people don't see research as a critical tool in national development. So that's also still a major challenge. So to summarize what we've done, we've typically seen a typical clinical science and public health research where you are ensuring that every child in that community, now with those almost more than 4 million children have received the drug, while at the same time we are also conducting research. Where we are conducting research, we are also mindful of that you don't undermine people, you don't expose persons to unnecessary risk, so that at the end of the day, it will be a win-win situation for all of us. I think I need to pause here so that we'll have time for questions. I think the Director General wanted to say something. Thank you, sir.
I was actually going to say one or two things about maternal deaths.
Yeah.
Because it came up in the course of your presentation. But I'll get back to that later. I want to come to SARMAAN project. And I don't know if I'm talking for our friends who are here. We've been talking about dosing with azithromycin.
Yes.
And establishing the fact that there's no antimicrobial resistance and all the rest. My question is this: why did we come about giving azithromycin in the first instance? I want to believe that's one question I'm interested in, because that will now take us to whether it's okay or it's not okay.
Yeah, thank you, sir. You know, this is a pathologist and clinician, so you always ask this question. You know, the neglected tropical diseases, onchocerciasis, schistosomiasis have been going on for a long time in the north, not only in Nigeria, but in Niger, in Mali. And they've used azithromycin to treat that. So after some time, when they do the secondary data analysis, they noticed that in communities where this drug has been used for some years, that infant mortality dropped. So they systematically start checking in all those areas and notice that persistent drop in those areas. So the first thing NIMR did is did a desk review and also went to the north, even before we started this project, to go to those areas where NTD estimation have been used for control of schistosomiasis. And we also noticed a drop in infant mortality. What people are still trying to is to look at the mechanism of action of azithromycin in reducing infant mortality, but is generally where it has been used for neglected tropical diseases, infant mortality is lower than where it's not used. But what people are beginning to think now is that some of the common causes of death in children is upper respiratory tract infection, azithromycin and antibiotics, diarrhea diseases, although majority are due to viral infection, but some are due to bacterial infection. So that might be mechanism. There may be other mechanisms. Some studies are going on trying to study the mechanism of action. But this is what actually led to WHO to come up with that guideline. And why that came up is because despite all they've been doing, immunization, nutrition, think about it, children are still dying. So the WHO said, if you have noticed that in these communities that use this, that infant mortality drop, maybe if you add this another layer, it's not saying stop what you are doing, it's just saying add this on top of what you are doing and see whether that will help to improve. Sir, am I able to answer your question? Thank you, sir. Yeah. So, he talked about maternal deaths. You know, that's also maybe next year when I'm talking again, I'll focus on that. This morning, DG and I attended a function yesterday where he presented the minister and I represented the DG. So I posted the picture on my class WhatsApp group, and somebody just said, he said, this obstetrician, you keep moving from one workshop to the other while women are dying. And my reply is that an individual obstetrician or physician will not be able to reduce maternal mortality. That maternal mortality in the country in Nigeria is a sign of systemic failure, a sign of some negative cultural practices that hinder women's health. The low status we place on women and not prioritizing issues that relate to women and children. That if you don't focus on these system issues, these infrastructural issues, these cultural issues, religious issues, it's not my portion syndrome. I'm sure you have people say it's not my portion. They are telling a woman about going to book at that clinic, go to that clinic so that she will have a safe delivery and that she will not die. The woman will tell you, it's not my, we call it not my portion syndrome. You go to places where a pastor and a man will say, I laid hand on you, and you deliver like a Hebrew woman. You are not a Hebrew woman, you are a Nigerian woman. And I tell people is that there's no way you can predict a woman who will die in labor or a woman who will survive. A woman, the pregnancy is, you can see a woman who will come into labor, who will walk into the facility, and before you know it, things get out of hand. So what it means that the only way we can reduce maternal mortality is that if we have every woman delivers under skilled bed attendants. And what WHO define as skilled bed attendants is only two categories of people who are skilled bed attendants: a midwife, an obstetrician gynecologist, or a doctor or a nurse that is trained in the act of delivery. That you are a doctor or you are a nurse and you've not been trained in act of delivery, you are not a skilled bed attendant. But we're in a country where people arrogate what they are not to themselves, and the population itself believes them. You are talking to a woman, you need to go. You know, God is a master planner. He could have said, you get pregnant today, you deliver today. But he decided to give you 9 months to plan for that delivery. The essence of that month is for you to start planning, start saving money. We all save money for Ashebi. We all save money for phone. We all save money for Ilea. We all save money for Christmas. But nobody saves money for hospital delivery. But you know it's going to come. And you tell a woman, your baby is not lying well, that the baby is lying across, that there's no way that baby will pass through the birth canal. And the woman is telling you, I reject it. One pastor and one imam say, I lay hand on you and the baby have turned. And you believe. So these are some of the things, or some people will say cesarean section, and mother-in-law will say, I delivered all my children through the vagina. Why should you be wasting my son's money? You must deliver like Hebrew women. When you are not a Hebrew woman. So these are, if you see the issues that relate to maternal mortality in Nigeria, is the health system issues, cultural, religious issues, and then low status of women. Once we focus on this, we'll be able to address the issue of maternal mortality. And once the mother dies, it's likely that that baby is likely to die. And once a baby dies, the mother is likely to get pregnant again. We call it child replacement syndrome. If a baby dies, now it takes 2 years for mother to fully recover from a delivery. But if the child dies, if the mother dies within 3 months, that mother is going to do what? Get pregnant again. And the risk of death, the safest pregnancies are the second and third pregnancy. By the time a woman is going to the fourth pregnancy, the risk increases. By the time a woman is more than 35 years of age and trying to have a baby, the risk also increases. First pregnancies are difficult, risk. There must be supervised hospital deliveries. I think journalists need to start advocating for us to do what is proper. There's no country in the world where they reduce maternal mortality with ad hoc arrangements. Or you say TBAs because you don't have doctors and nurses in the rural area. Or we say, the women don't like going to hospital. It's not true. Who will not see, who doesn't like a Sheraton? Who want to go to Sheraton and prefer one small hotel by the side? It's because they don't have option. It's because they cannot afford the hospital delivery. And it's also because the way we health workers treat them when they come to those facilities. Imagine somebody telling a woman, stop shouting. After all, I'm not the person who pregnated you. Why should you as a health worker say that? So when we say things like that, that will also push them out of the hospital. And also we have our own attitude. People get to hospital, instead of being calm to receive health care, you want to receive a 5-star hotel services. It's a hospital. It's not a hotel. Focus, be on the queue, come on time, and receive your services. Remember, those doctors and nurses who are in those hospitals are human beings. Some of them, one nurse will be the only person managing a ward where you have 20 women. And you want the person to do... So when we see a health worker, now in Nigeria, people have left. How many of us are still remaining? So when you see a health worker who is still in Nigeria, please buy that cold water to drink. Because if you continue pushing the person, the next thing, the person will choose Japan. So you could see is something all of us, not only the government, the private sector, individual communities also have to help. I think I need to stop here. Thank you.
Thank you, sir.
Thank you.
Still on the topic of maternal death, I'm going to focus on it from a different angle as a pathologist. Yes, it said that, and this for our friends to look at, spend some time going through this. I'm likely to just throw a lot of questions on the table for us to think about. Yes, it said that Nigeria has a very high maternal death rate. Now I believe that, but the question is this: do we really have the statistics? And we know that you can always use statistics to achieve whatever results.
Yeah.
It depends on how you try to interpret it. Is it also possible that part of the problem has to do with the population of Nigeria giving a bloated viewpoint? I'm just asking a question. I'm not making a statement. How do you get the statistics? One sure way of getting the statistics is by ensuring that you have a proper coroner system and you perform post-mortem examination. I was part of the team in 2005 that designed the coroner's law for Lagos State. And one of the things I insisted on was to put maternal deaths as a reportable death. And you find that in any civilized society. A woman dying during childbirth or shortly afterwards, it's not something that should happen. It's supposed to be a normal physiological process. So when it happens, you want to find out why. And when we implemented, at that time, the coroner systems 2007 for Lagos State, a lot of things were being revealed. Without trying to be offensive to some colleagues, you find that a woman dies and they're quickly encouraged to take the body away and not get to the mortuary for autopsy. Of course, I know I had to put my feet down as the head of pathology in Ikeja. But unfortunately, as President Ezechi mentioned, you have a lot of these cultural and religious factors coming in. Oh, we don't want an autopsy. Well, that's the way God created it, let it just go like that. But the beauty of the coroner's law was that you had no control over it. And at that time, you dare not move a body out of the hospital without having an autopsy done, whether it's in Ikeja or GH Lagos or mainland or what have you. Unfortunately, the coroner's law is not universal in the country. So all the places you are mentioning up north, nothing. Even in most of the places down south. So autopsies are not being done. And unfortunately, I have colleagues, anatomy pathologists, who don't like to do autopsies. So how do you now secure the statistics that you need? Perhaps we can use our influence in our write-ups to emphasize the need for the country to adopt a proper medico-legal system whereby you investigate this kind of problems and compel every state to adhere to it. In some parts of the country, it's no big deal for a young girl at 12, 10, 14 to marry. I think that was some time ago, a senator was marrying a 14-year-old girl. What's going to be the outcome during pregnancy, you will know better. What are the chances of that woman dying? Of course, you have the problems of fistula formation. And yesterday, I was discussing with some colleagues. We talked about this issue of coroner's law, autopsies, maternal death. And somebody said, wait a minute. Yes. Could it be that we're talking about this high maternal death because we're probably looking at mainly data coming from tertiary centers, where in the first instance you direct the patient to when the pregnancy or delivery is in a critical situation. And the person was saying that most of the normal births will happen at secondary or primary health centers.
Yes.
Or even with regards to the local midwives or traditional birth attendants, that perhaps if we try to focus on the entire spectrum, we'll be able to come up with more accurate figures. Somebody even mentioned the fact that there could also be the problem of access to the hospital. How many of our women die in the course of trying to go to hospitals? You talked about the issue of quackery. I just felt I should throw all these things on the table for us to look at. Unfortunately, that aspect of investigating maternal mortality cannot be executed by NIMR. It has to be a national thing. And I wish us luck.
Yeah, thank you. So to support what you said about the statistics about maternal mortality, we, in this SARMAAN project, we decided in some states to do enumeration ourselves. Because we realized that in, that was Castella, that we exceeded the number, Kaduna, that the number they gave us in the record. So when we started implementing, we realized that we had more children. Exceeded projected by more than 600,000. So what is likely is one of the things to do if you want to start addressing issue of maternal mortality and infant mortality, and that's what the role of NIMR should be, is for private sector and the government to support NIMR to do a national maternal mortality and infant mortality audit, a real prospective evaluation that will include autopsy. I'm not a pathologist, but from my little I know about autopsy cases, any sudden unexpected death qualifies for an autopsy. So, and most maternal deaths are sudden and unexpected. So it's already even in our law. When we are doing residency, that was during Olikoye's time. Every maternal death in Nigerian hospital must be reported. I still remember those days in Ife. And because of, you have to come and report. If a woman dies under your watch, whether the woman was just brought in and he just gave up, you must come and explain why that woman should die. It became like every doctor, every nurse, who now, we are accorded their pride of place. Once a woman comes in, you are not going to ask, have you paid money or not? Because if the woman dies in the maternal mortality review, which pathologists will come? And I remember some of the cases of deaths we had. And we are all speaking big grammar substitution. Until the pathologist will come and tell us the woman died from ammonic fluid embolism. And there's no way we can make that diagnosis. We could say, the woman had a preeclampsia, and had difficulty breathing and died. The woman had what we call ammonic fluid embolism, and the woman died. So some of these things, the essence of it is that if you do a maternal mortality audit, which involve multidisciplinary, the pathologist, the obstetrician, everybody, and the cause of death is established, lesson are learned, so that if such a sign you see it in future, you quickly recognize it and do. So I think the way to go is a national audit or national evaluation to establish the true maternal and infant mortality in the country, identify areas and the major causes. But the problem to have asked that the leading causes of maternal deaths globally are 3. But the question is that why is it now more people are dying? And the 3 things are: 1, bleeding, hypertensive disorders of pregnancy, and infection. These are the 3 leading causes of maternal anywhere in the world. But now the problem is that why is our own figures? If that's the same thing, I had a professor in Sweden, Backstrom, who when we had discussing, he said, I've never seen a maternal death. This is a professor at the time we met, was about 70 years. He said, I've never seen one single maternal death. A 70-year-old person, I've not seen. So that will tell you that it's something, I think journalists should champion it, issues of maternal and infant deaths, to bring it back to the fore. If the Ministry of Health can again introduce what Olikoye did past, that every maternal death in the hospital must be investigated. And it's a no-blame, Olikoye's that time is a no-blame review. You just want to establish the issues and lesson learned. Because when you start pointing accusing fingers at the individual, people will start hiding the facts. I remember those days, maternal death, you are presenting it, everybody's so open and looking at actually the real cause and lessons and learned. Thank you.
How do you want the question?
Good morning.
Introduce yourself.
Okay, good morning once again. My name is Mariam. I work with Premium Times. So I am still curious to know something about the administration of amitriptyline.
Azithromycin.
Zithromas, as we name.
Yes.
Okay. So you specifically said that you didn't want to mention the states that rejected the administration. But I would like to know, you should give a reason for the rejection. Looking at how important, the medicine is. And also for those states, for instance.
It's only one state.
One state, just one state. Okay. So for Kano State and Oyo State, elaborate on that.
Thank you.
That's my question.
Yeah.
Okay, my question is a follow-up to DG's question. I know you have responded to our question, but I'm still not, I'm still not
Satisfied.
with the response. Because I'm looking at the benefits of the drug. What is that in specific terms? That drug, what is it doing for those children? Then, I also want to know how often should the drug be administered to these children? And I am talking about the challenges, talking about inadequate laboratory facilities. I can still remember that during COVID, the NCDC said they have established some facilities, laboratory facilities, across the country. These are you didn't find one in those states.
I can't.
Also, I want to take you back to, I would also want you to let us know when you conclude your study on the HIV, hypertension disease stuff. I would also have an interest in that study.
Okay.
But I want to take you back on what you said on mother-to-child transmission. When you talk about babies not dying, so I also want you to let us know how many mothers have passed through this program and how many babies have passed through.
Yeah.
Thank you very much.
Thank you.
Yeah, go ahead.
A follow-up question. We're just looking at the WHO's recommendation on the mass administration of this drug, and they said it may have a short-term potential against malaria. How true is this?
Yes.
Kenny from Nigeria. I just want to know, sir, before administering these drugs to these children, sir, did you carry out any tests to know if they truly, some of these children, if they truly need the drugs, sir?
Any other
I want to ask what you mentioned the particular sickness in children that requires the administration of this drug. Can you, I think that the name you mentioned is a scientific name. Can you break it down? I want to actually know what exactly it is in children.
Okay.
Any other?
I don't know. You are raising your hand. You change your mind. Okay, Miriam. Thank you. You want to know?
I thought you want to.
Now I'm responding to Miriam. Thank you for your question. You want to know how the person, the state that said no is an individual thing, not the states. You know, in Nigeria, you can have some megalomaniacs who think that the Alpha and the Omega. So it's not a state thing. But by the time that person is no longer the commissioner, things have moved on. And how do we convince them? One of the things we do as researchers is what is called community engagement. Before you start on any research, the time has passed when you just hop into a vehicle and land into a community and start doing research. No. You do what is called community sensitization and engagement. Before, some of the states, specifically like Kano, we were there 5 or 7 times.
5 times.
Huh?
5 times.
5 times.
We are still there now.
We are going there, we are still there. You know, it's a continuous, it's not a one-off thing. We presented several times. There's a particular one I have to be there myself. They gather all the doctors in Kano, in all their specialists of everywhere. They were all there. Fielding questions. The thing about it is in openness. There's nothing you're hiding about it. You open it up. This is the research work. When you are doing research work, there are what we call equipoise, clinical equipoise. What it means that for you to do research, as the word means search, you are at the age, you have an inkling that this is likely to work, but you are not sure. If you are sure that it will work, it's no longer research, you implement. So at the point in time you are doing research, evidence is showing you that this is going to be useful, but you cannot bet and say it is, and that's why it's research. So, and that's why when we start, we have to engage the community. We'll start with the states, as far as the governor, the commissioner, the permanent secretary, the Ministry of Health, move to all the agencies that are related to child and maternal health. We engage the emirs, the emirates. There's a particular emirate in Kano when we're about to go. We're almost done. And the Emirates said, they said, we've not informed them. We have to pause in that particular Emirates and then do community engagement, communicate with them, tell them what we are doing, and they will after they agree that we now decide. So we are very flexible. Once we have an issue, we'll pause and address the issue. And that's why it's implementation science. Implementation science means as you are implementing, you're also watching out for possible barriers, solving issues, you address them, and you continue with it. So is you engage, and then we also obtain ethical approval from National Health Research Ethics Committee, from all the states ethics committee. You see, all the stakeholders that are involved, we're already even engaging them. All these things have to happen before. It was at the 5th visit in Kano that the commissioner now said, we've had you, we want you to come to Kano State and do this. Is there anybody in this room who have any objection? And they said there's no objection, and that's when we started. So we have a team that engage the community, we continue to communicate, and we're also using, because of the enormous number of health workers who require, we're also engaging people. In Kano State, last Kano State alone, almost 800 and something persons or more research assistants, and these people are all from the community, and we train them from a week. You know when you are training them, when they go home, they also mention it to their people that this is going to, this is what is happening, and so that's what we do to convince people. Chioma asked, what is that doing? I mentioned that there are some drugs in practice in medicine that initially that are meant for some other things, but along the line you notice that they also work in some part. I'm a gynecologist, so I will use an example in gynecology. I'm sure all of you know about Viagra. All of you know about Viagra now. Yes, you are keeping quiet. Yes. Once you are talking anything gynecological, everybody keeps quiet. When that drug was being tried initially, it was not for what is being used now. It was in the process of trying to try it for that is that they noticed that people who are taking that drug, that the other a working one that's downstairs. So, and the company have made more money from that than what is originally proposed for. There's another drug we call misoprostol. It's the drug that is used to stop NSAID-induced ulcers. But we now realize that it's good to use it to induce labor. You just insert it in the vagina at time of pregnant woman. It ripens the cervix and the woman goes into labor. So a lot of drugs have been used that when they are used for something else, you notice something else. So it's the process of the NTD programs that they notice that, in communities where children receive this, that infant deaths was reduced, under 5 deaths. So based on that, and it's not one place, it's not two, it's not three. Studies have done, and this have been extensively reported in Lancet, in top journals globally. And they will also confirm that limitedly, also in the north, that also before we embark on this study. So what people are now thinking, people are now looking at what are possible mechanisms of action. Infections, morbidities, infections. And one of them is respiratory tract infection. You say I used a very big word. Upper respiratory tract, that means infection of the upper part of the breathing system. And there is a major cause of infant mortality. So people are saying, and azithromycin treats that. That's what people use to treat children with that. That might be. Some bacterial illnesses in children, rashes, that can lead to even later, if it's a smear, also azithromycin can do that. Some bacterial diarrhea diseases, but although we need to know that majority of diarrhea diseases are due to viral infection, that you don't need to take antibiotics. I wanted to mention that before somebody will report and say, once a child have diarrhea, give azithromycin. That's not the teaching. The teaching is that majority of diarrhea diseases in children are viral in origin. You don't need to give antibiotics. Just do your normal ORT and monitor the child, and the child will be well. Doses. WHO in that guidance says that they are not sure of how many doses that that is sufficient or enough for the children. In SARMAAN 1, we did that in different platforms. We are still analyzing that SARMAAN 1 report. In some platforms, we only gave once a year, while in some other platforms, we gave twice a year. We are going to analyze them and see whether one dose a year is as protective as 2 doses a year. Those are things that research is going to find out. Chioma talked about mother-to-child transmission. Since 2004, we've seen over 7,000 pregnant women who pass through our prevention of mother-to-child transmission of diseases, out of which some of them we are lost to follow up. Some lost their pregnancies early in pregnancy, like any other pregnancies. In total, we've had 5,717 pregnant women who have delivered in our facility over the years. And we'll notice that from beginning, actually, it's important to mention that I was employed in NIMR because of the issue of HIV pregnancy. That was actually when NIMR started the HIV program, and they noticed that over years, NIMR started in 2022, they noticed that women are surviving, people are surviving and getting pregnant. And I said, oh, who takes, and that point in time, if you refer a pregnant woman to any facility in Lagos, once they find out that they're HIV positive, they push them away. And that was one of the reasons why I was employed in NIMR, to provide as a research fellow in maternal health. And gradually over time, one of the things we did very early that have helped us in terms of ensuring that our maternal our mother-to-child transmission is comparable with anywhere in the world is because of the science. We know the science. At the point in time, they were telling mothers in Nigeria to take a single dose nevirapine, which you know is associated with antimicrobial resistance. In developing countries, they were not using it. And so when I came into NIMR, and they said national guidelines say you must single dose nevirapine, I say it's not under my watch as a clinician, as an obstetrician, to give single dose nevirapine. I'm going to practice the way it's supposed to be practiced. So I never gave any mother single dose nevirapine. I was using combination therapy. The essence is to make sure that we don't brew antimicrobial resistance. At that point in time, they called me they called me renegades. They called me a lot of names. I'm sure one time, the national program reported me to the DG at that time, who called me to the office and said, they say you are not following the guideline. I said the guideline is a minimum benchmark. When they're giving a guideline, it's telling you you cannot go below the standard, but it's not telling you you cannot go above it. And I said, as obstetrician gynecologist, it would be unethical for me to place a woman on a single dose of it when I know that this. And he laughed and said, you are the expert, go and do this thing. And so we've never had maternal mortality that was above, mother-to-child transmission that was above 1%. And in the last 3 to 4 years, no single mother who passed through our PMCC program have delivered a HIV positive baby. Once we see a HIV positive baby coming here, that means it didn't pass through our PMCTC. If you notice now in the clinic, but I'm sure Dr. David will talk about that when she will be their child. If you notice, our pediatric clinic is drying up. You know what drives the pediatric HIV clinic is that mothers are giving birth to HIV positive and they are replacing. If you go to our clinic on Fridays, that is almost drying up. You don't see children coming there again. Any child you see there is someone that come from outside. You talk about the malaria, yes, and we collected that data. Ajibai collected that. We collected that data, and we're analyzing it to see the effect of that. But our funders said they are not interested in that malaria and all those. But NIMR, as the responsible institution, nested that research work as separate from the. So when we are reporting this, we don't mention that component, as that's not what we are funded. So it's off the record. We didn't do that component research. It's actually for NIMR. Kemi, what was your question again?
I said I actually want to know if there is any test, maybe you carried out any tests on some of the students, so if they really need it.
Yeah, what happened, there's a difference between clinical care and public health. Public health means doing greater good for a greater number of people. And it's different from clinical medicine, one-on-one. What we want to achieve is what they call the health immunity. And health immunity is that when you provide a service for almost 80%, that will have protection across other people. By the time you start doing, imagine 4-point-something million children. Even if it's PCV, just checking their blood level alone, the cost will be, at that time it's no longer public health. That means you're moving into the realm of clinical medicine, where is one. I think I've addressed. Is there any question I've not addressed? You want to add something?
Just in addition, the dose you are giving is not therapeutic dose.
It's prophylactic, yes.
And it's 20 milligram per kg per dose. Again, as part of what Miriam asked, just to follow up, sir, we are not only engaging in entry. There's a second engagement which most research work fail to. Giving back the result to the community. I think it's one thing we've ensured. For every circle we go, for every data that is generated, before we go back in for another circle, there is dissemination of that information. So they are able to see what is it you collected, what is it you get. And I think in SARMAAN 2, we are even open to give answers beyond the state and the local government. Give to the community. Let them have the answer. And I think that's one thing that has helped us. So it's a two-way engagement. Engage before you go in, and then re-engage once you get your data, and then you give back. So I think it's what has helped. And I think that is what really we should be aiming at as a research institute or as individuals. Giving back to the society, telling them what the story really is, so that they can be better informed.
Yeah, what's also important to notice that the dose we are giving is a start dose. And antimicrobial resistance develops under drug pressure. But once you give a drug, you just give it once, and then next time you're going to give another one is about 6 months or 1 year. The antimicrobial resistance is not likely to, because you didn't expose that individual to that drug, substandard dose of that drug over a long period of time.
It's not available over the counter because people can abuse it.
Azithromycin is expensive. We also, there's a different aspect of SARMAAN we are also doing. We have a pharmacy sub-study where our researchers are going to all the pharmacists and the patent medicine in the community and assessing. In SARMAAN 1 we did that. We didn't see any azithromycin because I now asked one of them, which state we are we in? They were acquired from Nikono. I said, why are you people? He said it's expensive. That if I stock it here, nobody will buy it. So it's a drug that is very expensive. I'm sure during the COVID when people were abusing it, I'm sure you see how expensive. Up to now, it's a drug that is very, very expensive. Yeah, it's available, but it's not cheap. If you go and notice, the drugs that are commonly abused most times are usually drugs that you can easily achieve. And if you go and abuse a drug that will cost you almost 20,000, who will buy it? And the fakers thrives on mass production. They produce so much, so many people come, and they can make their money. But if it's a drug that will be expensive, before you buy a drug of 20,000, you make sure that.
It's actually expensive.
Yes.
Some reason when it was small, and we were only given, it was only prescribed at the hospital.
Yeah.
So it was also at the end we were able to even get it, and they gave us the specific name of a particular brand that we used to buy. So it's really, as at that time, it's available. I can't go available in that line anymore. So
Yeah. It is also easy to monitor. It's also easy to monitor the azithromycin we are using. It has a special color, it comes special package. It's not boiled to come. So if anybody are monitoring will see it in any pharmacy, you will ask yourself, where did you get it? Because this particular brand we are using is specially made for this purpose.
If I may ask, when
Sit down.
Kano, what we saw was mainly data collection and sample collection. Does it mean we're still going to go back to administer the drug?
Yeah, what we usually do, research work, we are trying to establish a baseline. Baseline means what the status quo was before admission of the drug. So we've gone there, we've collected the data, collected baseline infant mortality data, collected antimicrobial resistance. We don't want, maybe already, in most developing countries, the antimicrobial resistance profile is already high. And we don't want anybody to attribute what is already there to azithromycin. So we've gone now to go and establish, to collect those data, establish baseline. And now, immediately after, they will go and give the drugs. That Solina will go and give the drugs. In 6 months' time, because that's when if they give drug today, if you measure, they won't see any antimicrobial resistance. So in 6 months' time, we are going to go back again and collect another antimicrobial resistant samples to see. And they will do that every 6 months, and every 6 months they will dose. Every 6 months they will dose. And they want to see the trend and see, is it increasing, or is it decreasing, or is it stable?
Is that what you're going to do in the next?
Yes. Just like we're saying that the ministry, and what I've been very pleasing is that all subsequent ministers after Dr. Sagi endorsed this. Actually now, across the West African region, this program is called REACH. And our coordinating minister, Professor Pate, is the co-chair of the REACH network across West Africa. So that will tell you the government commitment, at the level of high-level government commitment to this activity. When we are doing SARMAAN 1 closeout, which hopefully will be in August, that some of the journalists will be invited to come when we are presenting the result for the first time. And, thank you.
Any other question?
I think we had enough. Yes?
Prof, sir, I would like to ask for the WHO to approve the administration of the drug on children. That meant that there wasn't so much of a side effect on the children. But were there no complaints of a serious side effect from the mothers?
We also collected. He will share some summary and pictorial infographs with all the team there. The people will complain, even if you take water. People will complain, even if you take paracetamol. But what we usually do in medicine is that the benefits of what we are doing should outweigh that. But the complaints are normal complaints. Everybody complains with even taking ordinary water. It's not something that is something anybody should be worried about. I will just say that by and large, the side effect azithromycin is a drug that has been used forever. It's not a new drug. He mentioned, he said when he was having his children, that will tell you it's a drug that has been there, using as a safety profile. But we just wanted to say, when you do it for one-on-one clinical profile, it's different from when you now do mass distribution. That's why we are now doing that measurement. Otherwise, if you one-on-one, we don't need to do that. Thank you. I think we had enough for today.
I
I don't really have much to say beyond thanking us for making it here today. I'm seeing some new faces. We appreciate your presence, and it's my hope that we've been able to appreciate what our clinicians are doing here in NIMR. It's my personal intention to see more of clinicians doing things that will directly affect healthcare management, directly impact on the common man on the street. And I want to believe that as we proceed in this journey, we'll be able to achieve these things. I want to seize the opportunity to say a big thank you to Professor Ezechi, Dr. Akinsolu. Did I pronounce it well? Yes, sir. And Dr. Salako. For their presentation, educating us on what the SARMAAN project is all about. And I believe that in the next few months, they'll come back to share with us what's going on in other areas of investigations. Again, I say a big thank you to us for coming.
Thank you, sir.